So before I even call the person as being refractory, I have to make sure of certain things. One is, that they are actually adherent to the medication. And, nobody likes to take daily medicines. And the question I ask there is, who is supervising your medicine?
About 30% of people with an epilepsy keep having seizures despite trying all of the anti-seizure medications that usually work for their type. And I personally do know what that is like. So how do neurologists and the person with the epilepsy, and often the carer too, how do they decide what to do next? Well, today, neurologist Dr. Manjari Tripathi is going to explain how treatments and seizure preventions can go beyond medication, for instance, like lifestyle changes, and then the epilepsy surgery pathway. So figuring out who's suitable, the preparation process, and also how we need to look at the person as a whole, as a fellow human, who is as worthy as you or I, and not just some statistic who happens to have an epilepsy. Thank you so much for joining us today, Manjari. Could you tell us a bit about yourself? And what do you do? Where are you from?
So I'm from Delhi, India, from the All India Institute of Medical Sciences. I'm the head of department there and the clinical lead for the Center of Excellence for Epilepsy Care at our center.
Well, going straight into things, when people think about epilepsy, and I totally get this because I used to think this, people just generally think about medication. But tell us about how effectively caring for people can involve more than just giving them drugs.
Epilepsy is more than just seizures. 70% of people with epilepsy are controlled with one or two medications. But then they have their whole life. They have the spectrum of their aspirations, whether it's education, whether it's a job, whether it's marriage, whether it's driving, whether it's holidaying. So they have the same aspirations as any one of us, So, and also along with that is the impact these people have with the misunderstanding that the community has about this disease in terms of getting stigmatized, being made to feel different, and then having anxiety and having depression and in few cases psychosis associated with it. Then the unexpected nature of the disease, which makes them amenable to falls, injuries, burns, and sometimes, sadly, even losing life. So it's epilepsy is just not just seizures, it's much more. And particularly when the seizures are not getting controlled with one or two drugs, what we call as drug-resistant epilepsy. So we have a treatment gap for epilepsy, but we have an even bigger treatment gap for drug-resistant epilepsy.
Yeah, indeed. And it's a crazy percentage, right? The 30%. It's nuts when you think about that hasn't changed much over the past few decades. So
no, unfortunately, no. Yeah.
We're not yet. Hopefully, fingers crossed, things will get better. So when you are thinking then about treatment, what are the processes that you need to go through, you and the person, because it's a two-way, it's like a team, isn't it? When you're thinking about certain treatments, what processes do you have to go through? So like EEGs, MRIs, what do you have to consider?
Yeah, so almost every person, the diagnosis is based on the clinical history. And we try to differentiate right from the beginning, is the seizure focal, that is coming from a local area of the brain, or is it generalized coming from the whole brain? That's the first thing we have to do, or is it something we can't make out? And then we try to get an eyewitness account, some home videos or situational videos from the CCTV. And the EEG corroborates the diagnosis. It doesn't, a negative EEG does not rule out the diagnosis, absolutely. And we have to do a neuroimaging. In our part of the world, it's a CT. And if the seizures are not controlled, epilepsy protocol MRI is what is done. So essentially, this is what the investigations are for people with epilepsy. Now, 70% of people with epilepsy, as I told you, will get controlled with one or two drugs. And in many of them, we will be able to find out the cause. But 25% of them, the cause remains unknown. And, we try to find out whether it's a structural cause, it's a genetic cause, it's immune mediated epilepsy, or it's some kind of lesion which is going to produce resistant epilepsy, like cortical dysplasia, etc., etc. So we try to find out the cause. Yeah.
And so once you know the cause, and especially the cause of the refractory epilepsies, at what sort of time do you bring up surgery or other treatments other than drugs? And also lifestyle changes, because that can be something as well.
Absolutely. So before I even call the person as being refractory, I have to make sure of certain things. One is, that they are actually adherent to the medication. And, nobody likes to take daily medicines. And the question I ask there is, who is supervising your medicine? And if the person, in India is taking the medicine on their own, then very often they are likely to forget it. So we always make sure somebody is supervising the medicine, or it's, alarmed into their mobile phone. So one is they're adherent. Second is we have to rule out functional dissociative seizures, which are due to emotional reasons or psychological reasons before we say it is refractory. Third is we have to make sure they follow certain lifestyle rituals, like timely sleep for 7 to 8 hours, and of course not taking too much of stress, not taking medication which can provoke seizures. We know common painkillers like tramadol, we know certain antibiotics can trigger seizures. So we go into this history, and the doses of the medicines also have to be appropriate. And the medicines also have to be appropriate. For example, a person who has generalized epilepsy, if the seizures are coming from the whole brain and we use drugs meant for focal seizures, the seizures will continue, particularly if it is a genetic generalized epilepsy. So you really have to see that the medication is appropriate to the seizure type and the seizure syndrome. Now, once we've established that all these factors have been ruled out and the person is truly refractory, we get them in for advanced investigations, which is epilepsy protocol MRI, which is a 1 millimeter section MRI. It takes about 45 minutes to do. And then we do a video EEG where we admit the patient and we record seizures, typically 3 or more seizers, which are the habitual seizers, to localize from where the seizures are coming from. If we can match the imaging with the video EEG, the patient need not undergo any further investigations and can undergo surgery based on concordance or, the matching of the video EEG findings with the MRI. However, if there's a discordance between the video EEG and the MRI, we do further investigations like ictal SPECT, PET, MEG, and sometimes invasive monitoring also, to determine from where the seizures are coming and, tackle that area by either removing it, which is resection, or by disconnecting it. So these are the modalities for refractory epilepsy.
And how long on average do you wait, assuming a person is managing to take all their medications, adjusting their lifestyle? How long do you give a person to taking the medication to find out, okay, we need to look at surgery?
Unfortunately, my center is the largest tertiary referral center in the whole of North India. And we get patients as late as 20 years, 22 years, 25 years into refractoriness, because there are several reasons for this. One is that there is lack of awareness and lack of knowledge. That is what your channel is going to do for us. It's going to generate awareness that, hey, if your seizures are not controlled with 2 drugs, and you've been taking them regularly in good doses, please go to a center which evaluates for drug resistance early, by the 2nd or the 3rd year. Don't wait for 20 years, because in these 20 years, the patient has lost out on education, on job opportunities, on, cognition, the memory goes down, it affects the behavior, it affects the mood, and all domains of existence get affected, So the earlier they report to us, the better.
I love what you just said, all domains of existence. You could not have put that more succinctly. That is it. The epilepsy affects your life.
So for minimizing this, what we've done is we've made, booklets and handouts for general physicians in our community, which is a simple tool which helps them check. So if the Seizure is not responding to two medicines, if there is something on the MRI, refer. It's as simple as that. And so that's how we get our patients a bit earlier. And, even when they come to us early, there is a process because we admit them, then we do the test, then we have our patient management meetings, and then we go in for surgery. So this whole process itself, even after coming to us, may take about 6 months to a year to reach to surgery, depending on how complex the network is.
Yeah, exactly the same over here in the UK. It takes a while, doesn't it? And you need that multidisciplinary team. Yes, the neurologist, but the psychiatrist, the neurophysiologist, the whole shebang. So, yeah, if anyone likes being the centre of attention for a while in a cool way, get yourself referred for looking into surgery. And actually, speaking of that, what percentage of people on average are suitable for surgery once you started looking into it? Because not everybody is.
So, when we're a centre, surgery is not the only option. And if 30% are refractory, we do all these investigations. About 60% to 70% of them will be candidates for surgery. But a good 30% of this 30% will not be candidates suitable for surgery. There are different types of surgeries, so 30% will not be suitable for any surgery. And that's where we are very on the board with diet therapies. And we found a lot of success, not just in children. We worked with adults and adolescents, and these diets are very good. They're as good as adding a new anti-seizure medicine without the side effects of the anti-seizure medicine.
And are you talking about ketogenic diet here?
Yeah, absolutely. So we have worked with modified Atkins diet, ketogenic diet, and low glycemic index diets. Because, in the children, ketogenic diet can be given because they haven't got conditioned to adult, to food, the normal food which everybody has. But in adults, it's very difficult to implement the ketogenic diet in its purest form. And what we do is we modify it with the modified Atkins diet, which is more acceptable, the low glycemic index diet, which is more acceptable than the ketogenic diet. And we found it to be as useful as the ketogenic diet. And we've published our studies in very good journals. So really, that's an option we give. And the other option we give our patients is to reduce the autonomic component of the seizures. And we offer all of them a yoga module, which is again published. It's our research work. The yoga module helps reduce the sympathetic tone, improve the parasympathetic tone, and has been known to reduce the frequency of seizures and improve the self-esteem of the patient. So it's not just surgery. There are various other options available to us, which we offer our patients, which are those 30% which cannot go in for a definitive resective surgery or a disconnective surgery or a neuromodulative surgery.
I love you bring up yoga. So when I was in India a few years ago, people were yoga, yoga, yoga. And I was thinking, as an ignorant person, thinking, what are you talking about yoga for? And now I say generally in India are like a world leader in the potential impact of yoga for improving quality of life and potential seizure reduction and improvement in mood as well.
So it's not just surgery, it's multiple things which can be offered. Sometimes, a lot depends on the family support. A lot depends on, how much financial constraints they have. Of course, in our center, we do have various government schemes, which, even care for surgery. So there's free surgery, there's free medication. But however, we still can't reduce the impact of the duration lost. That is 20 to 22 years to reach us. Yeah, absolutely.
Yeah, well, I guess, and that's why we're doing this, isn't it? To get people to come forward and ask for insight into or research into the surgery for them. And so you've done papers on quality of life. It's not just about seizure control, and you're involved in an international ILE project on that. Could you just give us a little bit of insight? Where are you with that now? Have you discovered anything so far?
What we found is that if people with epilepsy engage in physical activity, that is, they have a scheduled exercise program or physical activity program. In fact, in our, patient series, we've had people who've run marathons with epilepsy, people who've, gone cycling all over in, different places, and participated in Paralympics too. So sports and physical activity is very important to improve the quality of life. A person with epilepsy feels very confined to the home. And to mitigate that, we offer them these programs. We also advise them yoga. We also advise them group therapy sessions. As I told you, we have a patient support group where once a year we go on a picnic with our patients. So they feel very involved with the program. Apart from this, we work on offering them the assessment of their mood. They're very simple scales which we have standardized for the Indian population. So looking at the possibility of depression and anxiety, which is seen in 60 to 80% of people, and very often we don't even ask them how you feel. Have you ever felt that life is not worth living, or, you don't care about what's happening around you, nobody cares about you. So these kind of negative emotions are picked up with the brief scales we have. And then early interventions along with our neuropsychiatry colleagues, along with the psychology colleagues, goes a long way in improving the quality of life. The other thing which we found, which we've published too, is expressed emotions. If I'm a person with epilepsy, how do people around me express their emotions, conveying the unpredictability of the disease, or conveying the burden of the disease which is felt by the caregivers or the family. Is it a positive expressed emotion? Is it a negative expressed emotion? So we found that families where there was a positive expressed emotion, the patients did better, and they had better quality of life. Whereas there were families where, unfortunately, due to lack of awareness, there was a negative expressed emotion. And so this gives us a window of intervention where we could work on these families and tell them, hey, this is how you communicate. So communication in epilepsy, communication by the doctor to the patient, by the caregivers to the patient, and by the community, by the school, the principal, the school teachers, the children in the school, or the workplace people, is very, very important. Supporting a person with epilepsy, particularly when the seizure happens. Very often in school, what happens is that other children start giggling or making fun of the person who's fallen down because they wet their clothes. So communication is also a key in improving quality of life.
Thank you so much, Manjari. Brilliant.
It was amazing. Yeah, it was amazing. And I hope it does help us reduce the number of years before which the patient comes to us for intervention.
Thank you to Manjari for showing such care and empathy for everybody affected by the epilepsies, and seeing beyond seizures as well, in order to improve people's quality of life. In our next episode, we are going to follow on with Manjari's colleague, neurosurgeon Dr. Sarat Chandra, who is going to go into how epilepsy surgery works, the preparation, the types, and why it should not be seen as scary as it is by many. Do subscribe to support our channel if you haven't already, and see you next time.